whose first point of contact is not necessarily a hospital bed, but the doorsteps of a Kenyan home. We are reversing the old logic of waiting for people to fall sick, finding hypertension before stroke, diabetes before complication, a high-risk pregnancy before the emergency, and disease before disaster. The national government continues to match county government contribution to CHP or community health promoter stipends shilling by shilling. From this level, when a patient requires further care, the next part of the journey begins. Through the Primary Health Care Fund, eligible services at level 2 and 3 dispensaries and some level 4 health centers are financed by government. So far, the fund has received 27.4 billion shillings in budgetary allocation and disbursed 23.3 billion to support more than 20 million outpatient visits, benefiting over 15 million Kenyans. As we said, walk in, receive treatment, walk out, just as we promised. And I want to commend facilities, both public and private and faith-based, for working with us on this endeavor. This is a fundamental shift. Prevent what we can, detect what we cannot prevent, treat early what we detect, and refer efficiently what requires specialized treatment. And when a Kenyan requires admission, surgery, or specialized treatment, the Social Health Insurance Fund provides the next level of protection, built on the principle that everyone should contribute according to their means and their ability, but no one should be denied care merely because they cannot afford it. That is why the government of Kenya has sponsored nearly 560,000 vulnerable households, covering approximately 2.2 million Kenyans, while Lipa SHA Pole Pole enables families in the informal economy to contribute progressively according to their circumstances and means. Today, 32.3 million Kenyans are registered with the Social Health Authority. 8 million have received treatment. More than 1.5 million mothers have been supported to deliver safely, and more than 500,000 surgical procedures have been supported and paid for. These are significant numbers, statistics, as some would say, but behind every number is a human being, an anxious patient, a worried parent, a frightened child, a health worker doing everything possible, and for a life to be restored or saved. Consider, for example, the case of Lydia, an 18-year-old student and her mother, Naomi Mutendwa Kilunda. When Naomi's assistant chief encouraged her to register with SHA, she enrolled and listed her children as dependents, as is required. She could not have known then how much that decision would matter. Lydia later developed severe breast overgrowth that affected her mobility, her confidence, and her life as a teenage girl. She required specialized surgery at Kenyatta National Hospital costing $168,000, a bill her mother could scarcely have afforded. But because Lydia was covered, her surgery was paid for, and so was her recovery. Today, she is back in school, preparing for her Form 4 examinations. Or consider Christine Awino Onyango, a 42-year-old widow from Kisumu County, diagnosed with stage 2 esophageal cancer. Until recently, Christine would have confronted two enormous burdens: the cost of highly specialized treatment on one hand, and the additional cost of traveling hundreds of kilometers to Nairobi to receive it. Instead, she received specialized care at Jaramogi Oginga Odinga Teaching and Referral Hospital, including surgery, intensive care, and post-operative management. Her medical bill exceeded $250,000, yet her annual SHA contribution was only $7,000. Her bill was paid by SHA. So, when people ask, what happened to the bottom-up promise, to the mama mboga, the border guy, the farmer, and the ordinary working Kenyan, I say this to them: look at Christine, look at Lydia, and consider the millions of Kenyans who can now walk into a health facility and receive care. What could be more bottom-up than that? That is the transformation we promised. It is the transformation we have delivered. But the journey does not stop there. For some Kenyans, treatment is not a single visit, or an admission, or a procedure. Cancer, kidney disease, and other chronic and critical conditions can require care for months or years, with costs capable of overwhelming a family and their entire savings. That is where the next layer of protection comes in: the Emergency, Chronic, and Critical Illness Fund, established to ensure that prolonged or critical illness does not become a sentence to financial ruin. The same fund protects Kenyans when care cannot wait at all, in moments of emergency, when someone collapses, when a child cannot breathe, when there is an accident on our roads, or when a mother develops complications during a delivery. Nobody has time to compare prices, search for telephone numbers, or negotiate deposits. That is why earlier this month, we launched the SHA 922 Lifeline and National Ambulance Dispatch Center. A free call connects a person in distress to emergency care, with evacuation and the first 24 hours of stabilization covered whether or not the patient is registered with SHA. No deposit, no guarantee, no relative running around one office to another looking for money while a life hangs in a balance. And this is because Article 43 of our Constitution does not say emergency care is available only to those who can afford it. It says no person shall be denied emergency medical treatment, period. We are finally giving practical meaning to those words. Financing patients is only one side of universal health coverage. The other side is the facilities treating them, which must function. Through the Facilities Improvement Financing Act, public health facilities and all other facilities can retain and reinvest their revenues in medicines, equipment, and better patient care. Since October 2024, Social Health Authority has received more than 209 billion and paid out 178 billion to contracted facilities across 47 counties. KEMSA's fill rate has risen from approximately 40% to, as you have seen,